Okay, well, this morning we are joined by Dr. Derebery, who for this group needs no introduction. She was a long-term colleague at the House Ear Clinic, and her career really focused on otologic allergy and Meniere's disease. She's had a very productive career and was a past president of the Academy of Otolaryngology. She is technically retired from clinical practice, but is currently still very active at House Ear Clinic and serving as the Chief Clinical Research Officer. So we're very fortunate to have her join us this morning to hear more about histamine and how it impacts us and our patients. So thank you very much, Dr. Derebery.
Okay. When I first came, I was recruited to what was then called the Otologic Medical Group. I had done a formal fellowship in allergy, and so I assumed I'd be seeing a lot of patients who had chronic ear disease. You know, they got allergy, nasal, and so it's going to go ahead and affect the eustachian tube. And instead, I kept getting these referrals, largely from Dr. House here, Dr. John House, for Meniere's disease. And we hadn't had a whole lot of exposure in Meniere's disease. In fact, I'd only seen one middle fossa in residency. But so I, got to recognize the diagnosis, as John said, by the history, and treating them. Many of the ones he sent were allergic, and I wasn't quite sure what to do with their medications. We were going to have them allergy tested, but they were on histamine. So deciding they were using sub-Q or sublingual histamine that had been prescribed by the doctors in the group. So I decided that I knew more than the collective wisdom of some of the most brilliant neurotologists in the country. So I stopped the histamine, stopped the sublingual, whether on Circ or whatever with this. And they all quickly got out of control. And after about the 12th patient that called and said they were having marked vertigo again right after I'd stopped it, I thought, I don't know what this stuff is doing, but I better start using it again, which I did. And they got better. So at the time, I couldn't really find any literature on it. And I thought, should I even be keeping them on antihistamines if they're on this histamine and, we're going to test them, are they going to have anaphylaxis, et cetera? I couldn't find a lot. All I knew was it worked. So since then, fortunately, there's been a lot of research, or at least a lot of publications on histamine. And in fact, there's quite a bit of, you all are familiar with clinical trials for this, with H3 blockers, et cetera, with this, to see if it might play a role in inner ear and other disease. So in this presentation, what I'm going to speak about is histamine and its role. And this is a non-FDA approved medication, Betahistine. These are my supports on this. I have foundation grants from the Cures Foundation and from the House Institute Foundation. I'm on the advisory board of Oticon Hearing Aids. I have my own company, own it. And then I have stock in Earlens. I don't think any of that's really going to be pertinent to this lecture, though. In this, we're going to discuss the evolving role of histamine in disease. We'll review the various types of histamine receptor types, and we'll review a role for histamine blockade in the inner ear. First of all, has anybody here heard of encephalitis lethargica? Well, probably most of you are suffering from that. If not now, you will by the end of this presentation. But
No.
And its role in how it fits into this histamine lecture. This is the historical background on history. It was recognized by Dale et al. About 1910. And what they recognized was there was something that was mimicking anaphylaxis, and they didn't know what it was. So later they isolated histamine from lung and liver tissues, and they named it after the Greek word histos, meaning tissue, because they figured out it was present in a lot of tissue. In 1937, Beauvais and Stowe identified the first compound able to block histamine-mediated anaphylactic reactions, and they actually received a Nobel Prize for their work. So, back to the encephalitis lethargica. World War I was not actually ended militarily. It was ended by the development of the Spanish flu in 1918, and it actually affected so many soldiers, and in particularly on the German side, that they were literally millions of people died around the world, and a lot of this began in the trench warfare in Europe. So that was the reason for the armistice, for the surrender there. One of the other diseases besides Spanish flu that developed was something called encephalitis lethargica, and it spread throughout Europe, although we didn't have much of it in the US. So a Viennese neurologist, von Economo, observed that there was a direct relationship between the degree of sleepiness these patients had and their inflammatory side. And the symptoms of encephalitis lethargica, you can probably figure out from the name, included excessive sleepiness, inability to speak, began to have double vision, neurological effects. So he somehow, on these autopsies, noticed a relationship between sleepiness and the amount of histamine or amount of inflammation they had in the brain. And especially the lesions seemed to be located in the posterior hypothalamus. So he theorized that this posterior hypothalamus must have something to do with sleep. Histamine is a biogenic monoamine synthesized from the amino acid histidine. It's produced at two sources, peripherally and centrally. And I'll keep going back and forth between its peripheral effects versus central, because most of you are knowledgeable quite well about peripheral. And again, maybe until you came to House, knowing about central effects was news to you. The primary peripheral source are the mast cells, basophils, and GI cells, enterochromaffin cells. And again, I'm sure you all know that from residency, histamine, mast cells, or circulating eosinophils. You put them all together when you think of allergy. The central source is a tuberomammillary nucleus in the posterior hypothalamus. And also there are brain cells throughout there are mast cells throughout the brain. In fact, mast cells are found throughout the body. Histamine itself is located throughout an entire organism with its highest concentrations in the lung, the skin, and the GI tract, not in the inner ear. And it plays both an immunologic and a physiologic role. I put this in this respect because for virtually everybody, including me, when I came to House, you think histamine is bad. I mean, there are billions of dollars spent on antihistamines every year and on advertising for them. Histamine causes sneezing and itching and running, etc. And so it's associated with the symptoms of allergy. And again, billions have been spent on the use of antihistamines and advertising for it. And that's the typical reaction to the word histamine. Nuke it, destroy it, block it, whatever we can do. That's done with an antihistamine specifically. Harner and Harris, started work on antihistamines when they noticed after histamine infusion that patients got headaches from it. And they developed antihistamines in the 1930s to clinical use to try to affect or stop these symptoms of allergy. And in particular, they wanted it for anaphylaxis. And since that time, there have been multiple sedating and non-sedating antihistamines that have been released. Again, it's a multi-billion-dollar field. These are the physiologic effects. Especially on central, allergic symptoms always involve inflammation. We're familiar with the vasodilatation. You have an allergic reaction, the shot, mosquito bite, whatever it is, though you're going to have erythema from capillary dilatation, chemotaxis, neurotransmission, and it's also involved with wakefulness, not woke, but wakefulness. It has a significant effect, though, also on central, and that's its very, very important role in balance. It also has a role in gastric acid secretion. We know ranitidine or famotidine in terms of H2 effects in the GI tract and on cognition. And also on this, actually, histamine is associated with appetite suppression and with lipolysis, and it's playing an increasing role or interest in its possible treatment for obesity. Histamine, in order to work, has to bind onto receptor sites, and there are 4 receptor sites that we've identified for histamine. It's very imaginative, H1, 2, 3, and 4 receptors. And the effects of histamine vary greatly, and it depends on which histamine receptor histamine is bound to. And depending on where it's bound, what type of receptor, we're either going to get predominantly peripheral effects, such as allergy, or we're predominantly going to get the central effects, such as on balance. What are the peripheral effects? I don't think I have to tell anybody here, you all know them. The most commonly recognized effects people associate with histamine are peripheral, and they consider them bad. Well, they are uncomfortable. The histamine is synthesized, stored, and released by both mast cells and circulating basophils. And histamine is definitely an immune mediator. And that's what we think about it with peripheral effects. We don't think about it in terms of its central effects. It also regulates, again, gastric acid secretion in the stomach. So it's not just allergic reaction. The vasodilatation, I think I've already covered that, except for I'll mention the sensory neural stimulation, including the sneezing and rhinorrhea. And of course, it's very involved with bronchoconstriction, which at its worst point results in anaphylaxis. We're going to be spending the rest of our time talking about the central effects of histamine. I keep emphasizing that we need to consider histamine as a neurotransmitter, just like we would any other neurotransmitter, because it definitely is. Its primary function is wake promoting and rapid eye movement, and it actually suppresses sleep. Like I said, probably many of you said, give me a whole lot of histamine right now. You know, I need this. It has an effect on feeding, endocrine activity, decreases appetite, and it may delay the development of leptin resistance, both in obesity and possibly in adult onset diabetes. What does it do as a neurotransmitter? And this is not as well appreciated, and certainly it's not, unfortunately, in much of the ENT world, and definitely not in the non-ENT world. It has it's centrally produced in that posterior hypothalamus. And again, the central effects are going to be determined by which histamine receptor in the brain and nervous system histamine binds to. So we'll talk first about H1 receptors. And H1 receptors are, again, the ones we think of peripherally, the itching, sneezing, and all we've covered. But it also has some very significant central effects. It's crucial for wake promoting effects. It also will bind. It will also, of course, give the peripheral symptoms that are uncomfortable, the rhinorrhea, congestion, etc. And we use the H1 blockers, the ones that received a Nobel Prize, to block the H1 mediated effects, peripheral effects of allergy, the peripheral effects specifically. The initial antihistamines, the first generation, also cross the blood-brain barrier, blood labyrinthine barrier, and they produce central antihistaminic effects. And what are these central effects? Let's talk about the first generation antihistamines. The first generation central effect, the first generation antihistamines after it crossed blood-brain barrier was sedation. And in fact, this is used to a clinical extent, and again, literally billions of medications. If you get something that says PM on it, like Tylenol PM, for example, it's virtually always going to contain a first generation antihistamine, often diphenhydramine. And it's also used for vertigo. It's often used as vertigo. We all know that the most common treatment for Ménière's disease is actually histamine, and they use it for its antihistaminic effects in the brain. Use it because it has a very significant suppressor effect on the inner ear and in the vestibular nuclei. The chronic use of these H1 antihistamines, which may not be appreciated by many, is it's associated with centrally with weight gain. Keep mentioning there's this now appreciated effect of histamine on weight and lipolysis, which is why one of the other reasons we don't want people to be on chronic first generation antihistamines, even if they say they no longer get sleepy from it, or even if they're in that small cohort that somehow gets wakefulness from it. So that led to the eventual development of second generation antihistamines to affect that H1 receptor. And this was something very much wanted and desired in the allergy world. The second generation antihistamines don't cross the blood-brain barrier. So their effects are largely peripheral. They have very little, if any, central effects. And again, this is what we largely use for the symptoms of allergy now. Allegra, Zyrtec, Zysol, etc. They're largely sedation-free, but they are not useful for the treatment of vertigo. And I'll see this where somehow Allegra is put in allergic patients who also have Meniere's disease. It's not going to do anything to keep them from getting dizzy. One thing it does do is it seems to not have the effect on weight gain that we see with the first generation antihistamines. So clearly, it's a better choice for peripheral allergic reactions, nasal symptoms, lung symptoms, etc. Okay, what happens when we get H2 binding? We get gastric acid secretion. And in fact, we use H2 antagonists that you're all familiar with to protect against heartburn and acid secretion. Ranitidine, which no longer is available, famotidine. These are specifically H2 receptor antagonists. Now they're used for GI effects primarily, but they do tend to have, for some reason, a synergistic benefit if you combine them with a second generation H1 antihistamine. In other words, if you combine it with an H1 antihistamine, these H2 blockers. So if you get somebody with, say, urticaria and you give them famotidine along with regular with H1 Benadryl, something like that, it's going to have a very good effect on skin reactions. It has some central effects as well, at least if you're a mouse. The central effects of these H2 receptor bindings are it makes mice less aggressive. Maybe we need them in our kitchens or something to get them, to stop eating food. There's a direct relationship between histamine expression and aggression. And that's felt to be related to a possible suppressive effect on the vestibular nuclei. That's suspected to be an additional effect of H2 receptor binding. H3 receptor stimulation is largely what we want to deal with in otology, or what we are affected, how it affects us. And this is the one where we're very interested in what happens if we bind those receptors or don't bind those receptors. H3 is a heteroreceptor. H3 has heteroreceptors present throughout the brain. H3 heteroreceptors are found in the cortex, the cerebellum, the dorsal thalamus, hypothalamus, and it regulates the release of multiple brain neurotransmitters. And specifically, what it'll do centrally is it will mediate the function of histamine in the central nervous system. An H3 receptor binding will. When it binds to an H3 receptor, it inhibits the release of histamine from these brain neurons, not from peripheral ones, but from brain neurons. So what happens? The central effects of histamine, again, regulate the release of other brain neurotransmitter. And when a histamine H3 receptor is blocked, we'll get the enhanced release of histamine, acetylcholine, dopamine, and norepinephrine. And in the opposite of the H1 generation antihistamine, it causes you to wake up. It increases cognition. Probably all of us would like to have some H3 blockers right now so we could stay awake through this lecture. H3 blockade plays a role in the treatment of ADD because of its role with wakefulness, Alzheimer's, schizophrenia. I don't really know how it plays a role in that, but again, it does play that role in obesity. And again, it's crucial for us to understand its role in the treatment of Meniere's disease. The H4 receptor, I'm only going to mention in that it was identified very recently in 2000. It's in the hematopoietic cells. It's somehow involved in inflammation, it's eosinophil migration, and it will amplify histamine-mediated immune response, at least peripherally. Now we're going to move to betahistine. And again, this is what we want to know about because it affects our world with Meniere's and actually with dizziness in general. And betahistine is the primary H3 blocker. It's the one on the market if you can get it, and it's the one that we associate with the word Circ. Betahistine. Circ is a trade name for betahistine. What is it? It is an analog of histamine. It's not actually histamine. It's, let's say, a first cousin. It's close enough related that it can actually bind into the H3 receptor. And when it does, it has an antagonistic effect. By the way, it has very weak, if any, H1 receptor agonistic or stimulating effect. So it's uncommon for a patient on betahistine to get either hyper, to get sleepy, or anything else. It seems to specifically work on the H3 receptors. And what happens when it does? It has an antagonistic effect, meaning that it enhances the central release of histamine from histamogenic nerve receptors. And again, from our standpoint, it enhances cochlear blood flow significantly. When you block H3 receptors, it increases the level of these neurotransmitters. I mentioned that, including serotonin. And that blockade also inhibits the activity of vestibular nuclei. So it does two good things for someone who has inner ear problems. It's going to stimulate cochlear blood flow, and it's going to suppress or inhibit vestibular nuclei, which of course with dizziness or Meniere's disease, we consider like all over the place, that they are, it's like an electrical thing that's short-circuiting out, and we want to go ahead and try to suppress that effect. H3 receptor blockade will restore balance and decreases the symptoms of vertigo. And this is a slide showing there's a cause and effect, direct linear relationship on the effects of histamine and what it's going to do into the cochlea. It also is dose dependent in terms of what it does on blood pressure. This is what happens if you give betahistine intravenously in the animal model. We can also measure, there's a relationship between what it does in strial vessels and the amount that's given. Betahistine is actually the most commonly used medication for the ongoing treatment of Meniere's disease in the world. And it is in the world, an exception is the United States. How do we feel like betahistine works for Meniere's disease, or why is it useful? Well, it depends on why you think Meniere's disease occurs. And of course, that's not totally defined, but in most cases, we do have endolymphatic high drops. And so the question is, do we have a relative overproduction of endolymph, or do we have, we have insufficient absorption? Nobody really knows, but we know whatever occurs is it results in periodic rupture or leakage in Reisner's membrane. When that occurs, we get these classic symptoms of Meniere's, in particular vertigo. Betahistine in Meniere's disease has an effect because we already know it increases the cochlear blood flow, and it's believed to shift the balance of production of endolymph versus reabsorption towards absorption. If you have a medical condition that is noted by a distension of endolymph, a distension of the endolymphatic membrane, meaning there's too much endolymph there, you would like to absorb it back to decrease that pressure. It's not approved by the FDA for the treatment of Meniere's disease. I always have to qualify that, especially in a CME talk or this or any kind of a lecture. If you look at the AAO-HNS clinical practice guidelines for the treatment of Meniere's disease, actually after reviewing about 400 papers, it was one of these things you thought, what do we put in it? Because we're talking about using a non-FDA approved treatment, but the official recommendation was for Meniere's disease, you can either offer diuretics and or betahistine, or put them both. It has a big role in the treatment of Meniere's disease. And it's also used not for initial vertigo attacks, but it's an ongoing maintenance, just like we commonly use a diuretic to reduce the symptoms or prevent Meniere's attacks. And it is much safer than diuretics. That's one of the ironic things about it. In 1970, it received its approval in Europe for the treatment of Meniere's disease. And in the early 70s, it was initially approved by the US FDA for the treatment of vestibular symptoms of Meniere's and dizziness. That approval was removed after 5 years. Why was that? Not because it was not efficacious, but there were questions that were raised as to how good the clinical trials were. Were they biased in some way? Did that affect the drug efficacy, et cetera? And there were enough questions that the FDA went ahead and removed its approval of it. And even today, because of that, there's very conflicting data regarding the efficacy of beta-histamine in Meniere's. It's just like the, quote, sham study in Meniere's disease, where there was endolymphatic sac decompression versus a shunt. So the decision was, well, gee, if decompression is placebo and doesn't do anything differently than shunt. Okay, well, we know it does. And we also know that there are problems with the way that the clinical trial on that, or the clinical trial on whether or not it was efficacious, was done. Same thing with beta-histine. On the cocaine review, again, and we, on the guidelines group for Meniere's disease, we reviewed this extensively, plus all of the literature from Europe on it. And the conclusion of the cocaine review was that Cochrane review was cocaine review. You can see what I'm thinking of the Cochrane review was most trials suggest a reduction of vertigo with beta-histine. Some of these show a reduction in tinnitus, but we all know there's no consistent treatment for tinnitus that's been shown, and I wouldn't recommend using beta-histine for tinnitus. I mean, I guess if it's not dangerous to do it, but it probably isn't going to do anything. One trial, and there was one trial on this, it did show that there was an effect of beta-histine on tinnitus, a positive effect versus placebo in 35 patients. But none of those trials on beta-histine, or actually no trials on any medication, has shown any benefit for the hearing effect of Meniere's disease. Everything we do, surgery, medication, it's always dedicated to the vestibular symptoms, to balance and vertigo. One of the reasons being that none of these things seem to have any effect on hearing at all. Again, a meta-analysis has shown a supporting role of the therapeutic effects of histamine for treatment of both Meniere's disease and for vestibular vertigo. You know, if you believe vestibular hydrops, which I do, or maybe it's on this continuum onto Meniere's disease. And we'll show there's no approved dosage in Europe or elsewhere as to what's the right dose of histamine. It sort of is, you try one, if it's not working, you go to a higher dose. It has been shown, though, that if you get to the really high doses of beta-histine, you get to using that like you would, like they do in Europe commonly, but not in the United States, at a dose of 144 milligrams a day, which does appear to be safe. It yields similar control of vertigo as the use of intratympanic dexamethasone. And I'm going to point out, since the treatment of steroids anywhere, including intratympanically, if you use it enough, patients are often going to become tolerant to it, or it doesn't work anymore. And beta-histine is something you want to consider very high doses. If you have one of those patients who had a good steroid response, intratympanic steroid response in the past to dexamethasone, no longer does, you may want to look at their histamine and really pump up the doses there to see if you can get a good effect, because it's not going to do any of that. Tolerance and to steroids is not going to do anything onto the effect of beta-histine. Low dose, and what I put on the objectives of this, how do we use steroids versus beta-histine today in the age of COVID? And I guess there is a new variant of COVID, the Eric something or other, that's beginning to raise its ugly head, because I'm seeing people going back to wearing masks, et cetera. So is there a role for beta-histine with this? Well, what there's a role in is trying not to use as much steroid wherever you use it. And we know that low dose dexamethasone is used in those severe COVID reactions during respiratory distress, those lung expressions of COVID. And of course, there's this overall concern with the overuse of steroids anywhere, whether it's for lung disease, whether it's inner ear or whatever. We also know that one of the first things, probably the first things most people do when Meniere's acts up, the symptoms act up, is we give them a steroid rescue, often anymore intratympanically. So if we use beta-histine with or without diuretics, it may very well lessen the severe vertigo attacks, lessen the need for steroid for inner ear symptoms. And when they do need steroids, should you need steroids, you can use those with beta-histine, because it doesn't seem to affect what beta-histine is going to do. It's still going to be efficacious. What are the pharmacokinetics? Peak onset of action is pretty quick. It's in 1 hour. Its half-life is 3.5 hours. It is metabolized in the liver, and it does involve it does involve or interacts with Mayo inhibitors. It is unaffected by food intake. Sometimes you want to have a patient take it with food if they get a little GI upset, but it's going to absorb just as well with or without food. And it's excreted in the urine finally. Again, I mentioned what's the most efficacious dose. Nobody knows. There are conflicting findings in the US. The typical dose we use is going to be much less than it is in Europe, 16 milligrams TID. And again, I put this because, in Europe, they tend to use 48 milligrams TID. And a problem, one of the reasons the FDA came down on the use of betahistine is there's often no placebo group in trials or no placebo group if we're doing dose ranging studies for betahistine to see, lowest effective dose. And also, as Dr. House keeps mentioning, it's not going to work in other areas of inner ear disease if it's not Meniere's disease. And we all know that there can be sometimes some difficulty both within the otolaryngic and outside the otolaryngic field as to diagnosing Meniere's disease. Okay, what's the recommended dose and efficacy of betahistine? Well, on double-blind, placebo-controlled trials with this, they were used with betahistine, 24 milligrams BID per day, 48 milligrams TID per day. Again, no consistent results, but if they followed patients on the 24 milligrams versus the 48 milligrams BID, after 9 months of treatment, stopping the treatment for a washout period, there was a decrease in severity of vertigo in both groups. There was no difference in the dosage or placebo regarding the outcome. I guess if I were going to give you a guesstimate on it, go ahead and start on a lower dose because the lower doses are probably just as efficacious on the bigger doses unless you get really betahistine tolerance. And then if you need to, you can definitely increase the dose like they do in Europe. And again, I kind of touched on this. Are these higher doses better? Again, nobody knows. When you really have severe, uncontrolled Meniere's disease, nothing is working. Go to the very high doses. They appear to be safe. I talked about European doses frequently, 48 milligrams TID right off the bat, but they have safely gone to 100 milligrams TID in trials. And with that, they've had a significant reduction where nothing else worked for the symptoms of vertigo. And despite those, what are to us massive doses, there are very few adverse events because, again, this H3 seems to have its effect in the central nervous system on balance or cochlear blood flow, not on GI effects or anything. I keep saying this. These are our usual doses, 16 milligrams TID. Push the dose if you need to. Now, what are the problems with betahistine? Well, number one is it's not FDA approved, and you should tell that to every patient when you're giving them that. And because it's not FDA approved, it has to be compounded, which means in the States, you can either get it from a compounding pharmacy or you can get it from a Canadian pharmacy. The compounding pharmacies, we have relationships with Burbank, the compounding pharmacy of Beverly Hills, et cetera. They know what histamine is. You give a prescription for histamine itself, betahistine, rather than trade name Circ. They'll compound it. Compounded medications tend to be more expensive than prescription medications. And of course, they're not covered by any insurance plan. At House, we give the names of Canadian pharmacies. Usually it's Universal Drugs that are very good about filling American prescriptions. And they recognize what betahistine is. Sometimes they'll get Circ, the generic, they'll get the brand name from Europe. Sometimes they'll use a generic form of betahistine, but they're very comfortable with betahistine. And as you know from your time here, yes, an American physician's prescription is good in Canada, unless it's for a controlled substance in there. It's good in Canada. Periodically, the feds will have something where they're going to crack down on US physicians using Canadian pharmacies, et cetera, but then that's always short term. And they know good and well they can't do it because our drug costs are so prohibitive in the United States. Safety of histamine, it is much safer than a diuretic. There's no effect on driving. We talk about betahistine. No, it's not going to make them sleepy. It's not going to make them not sleepy like a first or second generation antihistamine. Can you take betahistine if you're already on Allegra or Zyrtec? You know, do they like short circuit each other? No, they don't. The antihistamines, the lay public, most ENTs are familiar with, Allegra, Zyrtec, H1 antihistamines, don't bind into the H3 receptors. H3 antihistamines, quote, betahistine, don't bind into H1, so you can use them together and both get their pharmacologic effects. Yes, you can take them with allergy immunotherapy, and I had no idea what to do when I was getting these patients on betahistine when they were coming in for allergy testing, because I thought, you know, if I don't stop them on this, they're going to get anaphylaxis. It didn't occur. They can take allergy shots chronically and be on betahistine as well. They don't tend to stimulate asthma, and I'll put that, I say don't tend to. I have very rarely had a patient with asthma who noticed some increased effects with it. And it's been very, very rare. I don't hesitate to giving it to a patient who also has asthma. There's no effect on the cytochrome P450 pathway, though it may be affected by MAO inhibitors. Okay, what are the adverse effects, adverse events on it? Well, again, keep stressing, excellent safety profile, better than the diuretic. There have been under 130 million patient exposures since 1968. It is approved for use in 80 countries. There's been a 35-year post-market surveillance. In that time, there have only been 554 adverse events reported. They have all been reversible. They've been self-limited. And what they've been is, again, that small group of patients who tends to get an H1 effect of betahistine, and it's small, but they're all peripheral effects, you know, rash, pruritus, et cetera, that all stopped when they stopped the betahistine. They've also produced in some people headache, nausea, and vomiting, probably because they've had some effect on the H2 receptors in the GI tract. There have been no deaths from betahistine anywhere. There's been only one known anaphylactic, or we should probably say anaphylactoid type of reaction. And then there have been the occasional, I think actually just one thing that you see in every medication, which is a Stevens-Johnson syndrome. But again, that's very uncommon. So I keep talking about like it's a wonder drug. What are the contraindications? You know, the usual one. If you're allergic to betahistine, don't take it. I don't recommend its use in pregnancy or during breastfeeding, just because we have no data on that. Gastric ulcer, I wouldn't recommend it for that because, again, they're that rare patient that will get some H2 stimulation with it and get some GI effects with it and exacerbate or produce ulcers. We don't know how safe it is to use in children. We all know that it's uncommon to have children develop Meniere's disease or hydrops. And I'll tell you clinically, in my experience, when they do, they're not going to do well. They're going to be the type you throw everything in, it doesn't work, and they're often the type that's going to progress on to severe to profound hearing loss, no matter what you do. Contraindications, is it contraindicated in asthma? Not in my book. I mean, I've used it enough. And again, it's only a very small percentage of patients that get any kind of H1 stimulation with histamine, such as asthma. And then if there's pheochromocytoma, again, because it has an effect on so many other neurotransmitters, or histamine does, don't prescribe anything that's going to affect histamine one way or the other in that particular condition. So what is the research going on histamine? I know there's been a clinical trial recently on histamine. I believe that was the one that if Bill Slattery's on, I believe that's the one you were on, or maybe it wasn't a histamine, histaminic type of medication. I'm not SPL, I'm blanking what it is. The research, a lot of it has been in dizziness, and particularly in Meniere's disease. Why Meniere's disease? Because we can define the definition of Meniere's disease so well, as opposed to other types of dizziness. And there is a trial right now where an intratympanic form of betahistine is being looked at by Auris Medical. And honestly, I don't know if that's out in clinical trial yet or not. I actually don't. There's also some study on H4 receptor antagonists, but they're mainly done, they're not done for ear disease, they're done for asthma, they're done for maybe chronic pain types of syndromes, and even for inflammatory bowel disease, irritable bowel disease. And I'm not sure exactly how that's supposed to interact with the H2 receptor stimulation, but apparently someone who's much smarter than me, and that's a very, very, very low base to do that, has figured out that there's some effect there, agonistic effect with it. So in summary, histamine plays an important role in many immunologic and neurological pathways. The effects of histamine are going to depend on which receptor subtype is stimulated, whether it's stimulated or whether it's blocked, which one it affects. The research strongly suggests that betahistine improves the vertigo and general dizziness that we associate with Meniere's disease, possibly with other forms of vestibular stimulation besides classic Meniere's disease, patients who have chronic dizziness, for example. The Academy does recommend betahistine in our clinical guidelines in the treatment of Meniere's disease. In fact, we recommend it just as much as we do diuretics, which have also never been proven to work in Meniere's disease. However, again, for the sake of disclosure, it is still not currently FDA approved in the United States. Since there is a generic, Circ is a trade name in Europe, and betahistine is generic. Frankly, I don't think there'll ever be an attempt to get FDA approval, because once something goes generic, it's typically not going to be financially viable or important for a pharmaceutical company to get it approved. Okay, I know it gets confusing with this. Okay, she's talking about histamine. Tell me again what happens if histamine binds into this receptor, and does it block? What does it do? When does it block? When does it augment, etc.? So I'll be happy to take any questions you'll have on this.